Hello guys, welcome to the Parson series, and today we'll be doing some of the vascular retinopathies which are important and they are asked. Now you will find that these retinopathies may sometimes not be asked directly, but then too it is important to learn about them because when it comes to exclusion, because these may be there in the options when the question is asked about some other retinopathy, and if you know some important points about these retinopathies, it becomes easy to exclude them in the options. So in this list, the first is the acquired immune deficiency syndrome. Now if you talk about this acquired immune deficiency syndrome, a number of patients of this HIV will show you the retinal manifestations, and one important thing is the cotton wool spots. These cotton wool spots are present in about 50% of the cases. Now, though we know the generalized etiology of the cotton wool spots, that they are due to the retinal hypoxia, due to which they were found in the hypertension retinopathy also, but when it comes to specific why they are found in HIV retinitis, the cause is uncertain. Areas involved are free of infectious agents and the immunoglobulin deposition, and it is now believed that it is directly the virus related HIV. Now patients, those patients who are having the HIV, as far as ocular infection is concerned, one good example is your cytomegalovirus. So practically they are both synonymous. When I am talking about HIV retinitis, it is meaning to say that we are talking about CMV retinitis. And what are the other opportunistic infections? We have toxoplasma and herpes. Now as I always say, whenever you have got three options, all except MCQ could be there. Now in the present scenario, when they are saying that there will be 200 questions in the 3.5 hours paper, I don't believe that they will be asking you directly all except, but yes, they can give you a clinical scenario where practically you will have to do the all except thing, and again you can go by this options and you can get the answer. Now another important thing is your retinopathy in the toxemia of the pregnancy. Now one good topic where you can integrate the ophthalmology with the obstetrics is your retinopathy in the toxemia of the pregnancy. So I hope that there could be a question in which they are asking you about the ocular manifestations in the pregnancy, and again an important high yield topic, and this is occurring late in the pregnancy, exceptionally before 6 months and practically always in the 9 month. So this retinopathy of toxemia of the pregnancy is actually occurring towards the later half. It's very uncommon that you will have before 6 months, and usually you will have after 9 months. It has many of the characteristics of hypertensive retinopathy, and that is why if you go by the sequence, the first is your gestational hypertension. Yes, so we start with the gestational hypertension. Now what is the basic difference between the gestational hypertension and normal hypertension in a female? So a pregnant female may be a case of a systemic hypertension also, but when it comes to gestational hypertension, it means that actually here the hypertension or the BP is subjected to the gestation, and you can attribute the gestation as a cause of the hypertension here. Now slowly and gradually this patient may go in the pre-eclampsia. This patient may go to the pre-eclampsia. Now when we say pre-eclampsia means we have got BP 140/90. Along with this we have got the proteinuria. Now previously this definition was also including the edema, but now they have excluded the edema here because they say edema most of the times is a regular feature of the pregnancy. So pre-eclampsia is hypertension with proteinuria. Now if this patient starts having the convulsions, if this patient starts having the convulsions, then it is called as the eclamptic retinopathy, and it is this eclamptic retinopathy which is actually going to the toxemia of the pregnancy. So I hope you understood the sequence and how we can correlate. So what is actually the basis of this convulsion? So basically we have got hypoxia in the brain that is leading to retinal hypoxia, and that retinal hypoxia is leading to the changes. Alright, so if you go by the changes of the hypertension only, we will have the narrowing swelling of the retinal arterioles. We know that angiospasm is one of the earliest changes that we have in hypertension, and it is a nasal angiospasm. If you remember your notes also, always do first read your notes and then go by the textbook, so that it becomes easier to comprehend with the language of the book here. So you have the nasal angiospasm, the similar thing they are saying, and in which in any event are smaller, and this is followed by the spasmodic contractions. Now what they are saying, as the BP rises, edema appears, making it resemble the hypertensive retinopathy and in its most marked forms. So as the blood pressure will go on increasing, edema will go on increasing, and then it starts even resembling the hypertension retinopathy. The exudation may be so profuse and generalized to cause a severe retinal detachment. So all those changes that we are having in hypertension retinopathy, we are expecting here. We are expecting the superficial hemorrhages, that is your flame shaped hemorrhages. Then we are expecting the soft exudates. The soft exudates are actually the cotton wool spots, and because you know your hair exudation is so intense, that is why we also have ERD. So what kind of retinal detachment we are having here is the ERD. Now one important change that you have to keep in mind, that when we are treating or when we are having a patient of hypertension retinopathy or the toxemia of the pregnancy, the RD that we are suspecting is the exudative, while if we are having a patient of diabetes, there we are going to have the tractional RD. The occurrence of this disease puts a peculiar responsibility on the ophthalmologist, and any visual symptoms occurring in the later stages of the pregnancy must be investigated. So it actually, this patient will not be with the ophthalmologist. Obviously in the later stages of the pregnancy, this will be in the vicinity of a obstetrician and the gynecologist, and that is why it is pretty important for the obs and gynae people that they keep the patient in the track of an ophthalmologist. They keep on, you know, reviewing this patient, so that they are having a basic examination, and whenever they are following up, they come to know that what is the sequence of events that are taking place. So constriction particularly of the nasal branches, so obviously we are having the nasal angiospasm that is there, should at once call for the extreme care in the general treatment of the case. See, they are giving you guidelines. Now this can very well be a part of the question when they say that what is that important thing, where you start thinking that yes, you should start following this patient. So we have the constriction, particularly the nasal branches, the occurrence of arterial spasm together with an increase in weight. Why increase in weight? Because that means more and more edema. More edema means against the urgency there will be edema, and sometimes you are not able to get the or you are not able to find that this is edema, because generally also patient has gained weight during the pregnancy, so that you can find out when there is a gross increase in the weight and there is a retention of the fluid. That is a very, very ominous sign that you are going to get. Now the advent of retinopathy. As soon as the retinopathy occurs, that should call for a termination of the pregnancy, since its continuation will probably result in the loss of vision and perhaps of the life as well as the mother. Now this is a very, very important, I think extreme and awesome example of the integration, because this is one you can say therapeutic indication of the MTP, where you are having sole dependence upon the ophthalmologist. What they are saying, that if there is a advent of retinopathy, then there will be a call for the termination of pregnancy, since its continuation will result in the loss of vision and perhaps the life of the mother as well as the birth of a stillborn fetus. A very, very important thing. So this is one of the therapeutic indications of MTP, when you are terminating the pregnancy just to save the life of the mother or the life of the fetus. Timely induction of the labor, however, as well as the general adequate care will lead to recovery, provided gross organic changes may not have occurred. Even retinal detachment will resolve in these circumstances. Again, an important thing. Sometimes they ask you a question, if you look at the INI CET pattern, that option 1 is correct, 1 and 2 is correct, 1, 2, 3 is correct, or 1, 2, 3, 4 is correct. So one of the options could be that retinal detachment is reversible or not. So they are clearly saying that even the retinal detachment will resolve. If you are timely terminating the pregnancy, you can save the mother, the RD. Now the retinopathy of pheochromocytoma has got a similar features that usually affects the healthy retinal vascular system, and the changes are reversible. Again, an important thing, the changes are reversible provided the tumor is detected early and you are surgically resecting. Another important retinopathy is your sickle cell retinopathy. Sickle cell retinopathy, obviously this person will have sickle cell hemoglobin. It is an abnormal hemoglobin which is found mainly but not exclusively in the people of African origin. Now this kind of hemoglobin, when this person is deoxygenated, it becomes insoluble and distorts the normally discoid RBC into a characteristic sickle cell. So we all know this. This is basically the pathogenesis of sickle cell anemia, and these cells will actually obstruct the capillaries and leads to infarction, especially in the periphery of retina. Now we can have the frank sickle cell anemia, we can have a variant also. So variant C does not occur as frequently as the sickle cell anemia or the sickle cell trait, but it is the most important. What they are saying, that the variant called as sickle cell C disease. So if I talk about the sickle cell C disease, it may not be as common, but it is most important hemoglobinopathy in ophthalmology, because its clinical manifestation is predominantly seen in the eye, where you have retinopathy, you have angioid streaks, you have papilledema, cataract, glaucoma, we have circumscribed dilatation and constriction of conjunctival capillaries. And I will remind you that if you remember the etiology of the angioid streaks or the DD of the angioid streaks, what was it? It was actually the Pep C. So in the Pep C, this S is actually your sickle cell retinopathy. We have pseudoxanthoma elasticum, we have got Ehlers-Danlos syndrome, we have got Paget's disease, sickle cell retinopathy, and hyper-idiopathic. So one important place where you are learning the sickle cell retinopathy very frequently is your angioid streak. Another important thing, what is the most common one? So they may give you a clinical question where you have so many features of the sickle cell disease, and they may ask you which variant. So they are saying that this is not occurring frequently, but the most important, if we talk about the ophthalmology related sickle cell anemia, then it is the sickle cell C disease, because its clinical manifestations are very important and predominant in the eye. We have got the retinopathy, we have angioid streaks, papilledema, cataract, glaucoma, dilatation, as well as the constriction of the capillaries. Now if you look at the pathogenesis, now we have got the normal adult hemoglobin, that is a tetramer, and tetramer means the 4 units. So it is formed actually by 4 units of hemoglobin, and each of the 4 units is actually a polypeptide chain which is having 140 amino acids. 2 of the globulin units are so similar that they can be called as alpha, whereas 2 other are beta. Now it consists of 4 units. We have got 2 alpha, 2 beta because of their similarity. And if I talk about the normal adult hemoglobin, so normal one is called as the A1 and A2, different genes being responsible for the production of A polypeptide chain as well as B polypeptide chain. Now in sickle cell hemoglobin, the molecule is actually identical to the normal hemoglobin, except what is the pathogenesis? You must be knowing this. Yes, that in the 6th position of the B polypeptide chain, the amino acid valine is present instead of the glutamic acid. See, and this is actually a beauty of a good textbook. This is Parsons. So they may not actually have the obligation of explaining what is actually going on in this sickle cell anemia, but they have even explained it. So if you are reading these kind of books, it becomes easy for you to integrate the retinopathy along with the pathogenesis. Now if I talk about the hemoglobin C, the amino acid lysine will have been substituted for the glutamic acid in the 6th position of the beta polypeptide chains. And if I talk about the hemoglobin C, okay, so sickle cell hemoglobin C disease, this lacks a normal gene which is capable of producing the normal B polypeptide chain, and they therefore have no normal adult hemoglobin. So these patients are not having normal adult hemoglobin, and their hemoglobin actually is consisting of hemoglobin S and C produced by beta S and beta C polypeptide chains respectively. So what are kind of the fundus changes that we are going to expect in this patient? This patient is having non-proliferative as well as proliferative changes. The former begins with the occlusion of the peripheral arterioles. Now it has got both. We have got the non-proliferative also, and we have got proliferative also. The non-proliferative is as starting with the occlusion of the peripheral arterioles. We have neovascularization as well as the vitreous hemorrhage. While if I have, now again a very important thing which have been asked about 2 to 3 years back in the AIMS paper, we have got a fibrovascular proliferation that is creating a C fans, particularly in the supratemporal and periphery of the retina, a very important thing. So if they ask you about the C-FEN kind of a retinopathy, then certainly you know that they are talking about the sickle cell C variant. Now the retinopathy consists of, this retinopathy can consist of the tortuosity also, we have CRAO, we have CRVO, even the angioid streaks that we have discussed. We have got the sunburst spots, that is a focal retinal pigment epithelial hypertrophy, hyperplasia, migration that can lead to intraretinal as well as subretinal hemorrhages. Now we also have the optic atrophy. Retinal detachment can also be there, that is a late complication. So if you remember, the tractional RD also has one of the causes as sickle cell anemia. And look at the beautiful images here. You can easily see these are your C fans. So this kind of C fans retinopathy is actually found in the sickle cell disease, right? Now coming to the treatment. If I talk about the treatment, it consists of the sector photocoagulation that is causing the involution of the neovascular lesions, and we can also do the vitreoretinal surgery because we are having the retinal detachment. But you have the risk of anterior segment necrosis, because you know here the RBCs are not ready to tackle the stress of the ischemia and the hypoxia. So certainly you can have a problem of that. Otherwise it's a good treatment. Alright, now we are talking about the vascular disorders. So in the first one, we are going to talk about the obstruction of the arterial circulation. Now when it comes to the obstruction of arterial circulation, it is due to the embolus, and this embolus can be causing the superadded spasm, which is often completing that occlusion. It may occur without obvious general vascular disease, or it may be associated with arteriosclerosis, hypertension, Berger's disease. So these kind of patients where we are having this obstruction of the arteriolar circulation, it could be just the arterial circulation, or many times we have the generalized ischemic diseases in the person where we can have arteriosclerosis, we can have hypertension, or even the Berger's disease. Obstruction by an embolus is secondary to a plaque of atheroma which is situated at the bifurcation of the common carotid artery, or we can have disease mitral valve or aortic valve. So this is giving you a clue that in the question what kind of clinical scenarios you can have. You can have a patient of arteriosclerosis, 50 years male, having hypercholesterolemia, triglyceridemia, hyperlipidemias. We can have the atheromas, we can have the patients of hypertension, we can have the patients of the Berger's disease. All these patients can have the vascular disorders in the eye also. And if you look here, here they have shown you the embolus at the point of the branching. So this is your embolus here, can you see at the point of branching? So this could be there. So let's see the central retinal arterial occlusion, because this is again an important topic where we are going to have a lot of questions. Scenario, the obstruction may even affect either the central artery itself, where obviously if it is affecting the central retinal artery, then entire of the retina is affected, or it could be a peripheral branch where the effects will be localized. So scenario is nearly always at the lamina cribrosa. This you already know, the most common site is the lamina cribrosa. Vessels normally become slightly narrowed here. Now such an accident will cause sudden and complete retinal ischemia, and therefore there will be loosening of the function. The eye becomes suddenly blind. So what type of clinical features do you get? We get sudden painless diminution of vision in such kind of patient, and the causative factor is very small. It could be a emboli, it can be a premonitory obscuration of the vision, and when you do the fundus. Now when it comes to the fundus examination, what are you going to see? You are going to get a very typical picture. The larger arteries are just reduced to threads, so there is narrowing there, and smaller one will become invisible. Obviously within a few hours the retina loses its transparency, opaque and milky white. This is what you get. Why? Because we have lot of inflammation, we have collection of exudates. Which layer? Ganglionic cell layer. And that is why now the neurosensory retina that was transparent loses its transparency, become opaque, milky white in color, and especially near the disc and macula. At the fovea centralis, now they are telling you one important thing. See, at the fovea centralis, where the retina is extremely thin, red reflex from the choroid is visible and appears as a cherry red spot, presenting a strong contrast to the cloudy white background. So they have beautifully explained you the pathogenesis of the cherry red spot, the etiology of the cherry red spot. What is cherry red spot? It is not anything which is abnormal. It is not the collection of the blood, not the collection of any pigment. Rather, it is the only area where the choroid continues to shine through the fovea centralis, because this area does not have the ganglionic cell layer where we are having the collection of exudates. Other areas have become opaque due to the collection of exudates, and that is why they are showing a sharp contrast of this cherry red color in the fovea centralis, where choroid is shining, compared to the surrounding area which has become opaque and milky white in color, and that is called as cherry red spot. So a beautiful cherry red spot, can you see? And try to comprehend the language. This is your optic disc, this is your macula, and around that you are having this milky white color, but this area you are having still reddish area. So choroid is shining through those fovea centralis. This is your cherry red spot, right? Now when the obstruction of the blood flow is not complete, the flow may be partially restored, in which gentle pressure upon the globe may break up the column of the venous blood into the red beads. The beads move in a jerky fashion through the vessels, and that is called as a cattle truck appearance. So because of the obstruction, you know, the vessels are having the segmented column of the blood. So that jerky beads or the segmented column, this is actually called as a cattle track appearance. If the veins are easily emptied of the blood or arterial pulsations is produced by slight pressure, it is actually evidence of the incomplete blockade. Now suppose they are telling you this in the options, that the veins are easily emptied, or they are saying that the arterial pulsations are produced by slight pressure, then you have to infer from this that this is the evidence of incomplete blockade. The white appearance of the retina takes several weeks to clear up, but eventually the membrane regains its transparency and becomes normal. However, completely atrophic part of from the outer layers, which receive its nourishment from the choroid. Now what they are saying, that if you look at the immediate periphery of the optic disc in the macula, that area takes several weeks to clear up, but eventually the membrane will regain its transparency, it will become normal. It is however completely atrophic part from the outer layers which receive their nourishment from the choroid. But if you compare it from the outer layers which are getting its nourishment from the choroid, it is completely atrophied. The vessels are contracted, reduced, and you can also see just a feeble collateral circulation through the anastomosis. Disc will become atrophic. No direct pupillary reaction, the perception of the light is also lost. So if you talk about the pupillary reactions, because sometimes when you are getting a question and you are confused between optic neuritis, retinal detachment, CRAO, CRVO, so these things will help you. You will not have the direct pupillary reaction, and even the perception of light is lost. So actually there is total blindness in the patient's eye. Now in some cases, a certain degree of central vision persists in spite of the complete occlusion of the central retinal artery, which is due to the presence of cilio-retinal arteries, which always supply the macular area. So due to this macular branch, that is cilio-retinal artery, that will continue to supply the macular area, we can have the sparing of the central vision, and remaining of the field will be lost. Okay, in rare cases, cilio-retinal artery alone becomes the blocked. Now this is very rare, that just you are getting the area involvement which is supplying the macula, because the cilio-retinal artery that was supplying that macula has gone, but that is very rare. Sometimes due to the cilio-retinal artery we can get the macular sparing. So you have to remember both the things. Now after the CRAO, we'll talk about the BRAO. This is your branch retinal arteriolar occlusion. So only the area which is supplied by this branch is actually affected, not whole of the retina. In the early stages, the corresponding scotoma is somewhat indefinite, but later down it will form a permanent sector shaped defect. So whenever you are getting a sector shaped defect, or they are saying in the theory that there is a sector shaped defect, so that sector which is supplied by that particular branch will show you the blindness. Now treatment seldom happens, but a fair attempt should be made to relieve the spasm or drive an ambulance into a less important branch if the patient is seen early. So what are the things that we can do? Massaging the globe is probably the most effective method. Paracentesis, so we have to decrease the intraocular pressure, we have to mobilize the thrombus, we can do the ocular massaging, we can do the paracentesis, carbon mixture inhalation that we can do, and then we also give the systemic treatment, the steroids, the anticoagulants, all these things have to be given, okay. And inhalation of the amyl nitrate produces the vasodilatation. Normal result of an occlusion of the central artery is actually blindness. So we have seen beautifully the sickle cell retinopathy, CRAO and BRAO along with the HIV retinopathy. And suppose I give you a question on CRAO, I can have all these things in the options. I can have sickle cell anemia or sickle cell retinopathy, I can have CMV retinitis, I can have BRAO, I can have CRAO. So I think now with the description of each of these retinopathies, you will come to know that which indeed is the answer here and how to rule out the other parts. Thank you.